Okay, and we're back with Irene Watson, the OT at Waco ISD, and she's going to talk to us now a little bit about documentation once the IEP is complete. So Irene, tell us a little bit about how that the documentation process works from your end.
Well, as far as documentation is concerned, the IEP will tell us our frequency, our duration of what we're going to do. So we have to document each session, the time that we take during the session, what is our focus during the session, and we need to relate that to the goal, of course, that we are either integrated in or that we have developed for that student. We do that. We take data almost every visit. Sometimes, you have to establish a rapport. Sometimes you maybe more of a focus on talking with the teacher and integrating some things into the classroom for accommodations. Those are all documented. All that has to be documented, so we do that. We then provide the parent with updates of progress towards their goals, commensurate with their report cards. So if it's 6 weeks, that's when they get it every 6 weeks. Then they'll get what is their progress to each goal and objective.
Okay, awesome. So do you document on paper or is it in the computer system? How does that work?
Well, we've done it every way here in Waco ISD. Depends on what computer system they get for the teachers. But currently we're using the eShars system, which is a Medicaid type system through eShars, and where, they have modified it and accommodated to us so that we would have our documentation electronically done off-site, so we wouldn't have to worry about maintaining records and confidentiality and all of that. So we are blessed with that.
So that's good. And you mentioned Medicaid. So tell us a little bit about the Medicaid, because I know Medicaid documentation is a different ballgame. And do you, how you handle your Medicaid kids?
Well, first of all, you have to have an order from the physician to be able to bill Medicaid services. And it has to be, which makes it a little difficult. It's like if we are truly serving a student the way they need to be, every IEP will look different. It may be that we were seeing them once a week and they made great progress, and now we're seeing them once every 3. So every time there's a change, you need to get another doctor's order for that to go for Medicaid. So we do not have as many students as I would like on that right now, just because of staffing issues and not being able to put that at the front there. But really, there is no difference between a student that has Medicaid and a student that does not. We document the same way to ensure that we're consistent, demonstrating the need, and following best practices.
But it has to be submitted to Medicaid though, right? There's a submission process.
Yes, the system that we are using now will electronically submit that to Medicaid if that student has an order, a physician order. Then that's sent off to them. And
how nice is that? Back in the old days when I had to do it, we had to get that envelope out and we had to stuff it and mail it off.
Exactly, and send it. No, this is all done electronically.
Awesome. Okay. Which I did not ask you what evaluation. So back in the day, again, when I did this, the psychologist was the one that initiated the evaluations in the school. And when they would do their evals and something would come up with some functional problem for school, then we would get called in. That I don't know that that's the way that things are done now, but that's how it was. And that was in Louisiana where I was. But then we were told we could only do use certain assessment tools. Is that the way it is here? How do
the referral seems about the same? So you have either, the licensed school specialist in school psychology, who's either the case manager, so is pulling everything together, or you have the educational diagnostician. It can be either one. They're doing, what they do is they go and speak to the teachers. The teacher has to bring information to them. We have to try the RTI system. Once that's all done, and yet still the student is having difficulty, then that referral process for SPED has been initiated. Okay, so we want to do a full and individual evaluation of the student. So we try during they call them SAT meetings, really try to hone down on things that could possibly be the issue. So if it's just speech, we really can't understand the articulation, then it would be more of appropriate for a speech referral. However, if that is giving some trouble and now we're having behavioral, we'll probably come in and check some other areas. And if again, that student now he's not writing, he should be, then they may want to bring in OT as well. But we try to get that consent to the best ability, as informed as possible, so that every member of the team has the 45 days to complete that evaluation. So that is the same. With regards to your other
The
part,
tools. Yeah.
the tools. Okay, so in school-based, there, because we're under a related service under IDEA, and there is no qualification, there's not a score, unlike maybe in speech and language pathology where they have to have a 77 or lower, right? That is not the case. You can have completely average scores with the bot too, but you can't perform in that classroom, right? So we wouldn't say you don't need us. We may be looking at what is impeding that student. Is it communication? And then to achieve. So you may have average scores, doesn't mean you still don't need us. It means we're looking at a different avenue. So we have to look at the whole situation. That's why I'm looking at cognitive, I'm looking at behavioral, I'm looking at everything to see where it is, because it could be sensory. Okay, we need to help with that. So that's an issue. We do not have like a full battery of tests. We do use the bot too, VMI, theory VMI, to get some of those numbers that people like to have,
Right, right.
However, it is not mandated by IDEA that you have to do that.
We used to do that though, right? Am I wrong about that? Because I remember
there, and what's kind of scary sometimes is, and some people have probably experienced this, IEP can say they need OT, even if you say they don't need OT. So because it's to benefit the students' access to their special education. Okay. And so we have so many areas that we can help it. Does that make sense?
Oh yeah, yeah. Okay, that makes a lot
That's
of
why
sense.
your evaluation is really functional performance driven, and we're going to go down the rabbit hole and dissect all areas to see if there's a need. Other times, we can, if it's very bad fine motor, well, your bot's going to find it. You see what I'm saying?
Right.
Or if it's very bad visual motor integration, your Beery is going to find it. You know what I mean? But
so it's almost like they're saying, okay, they could put us on everything, but they won't give us the staff to do it. Is that
that's the cases? I think really what the intention of the law is not to restrict us to just scores, right?
Right.
So we're not denying students based on scores, because remember, since we don't qualify a student for special education, it's a service that can be provided to all. But the way Adriana and myself do it is we're looking at what is this really impeding? Do you really need the expertise of an OT
to learn, right?
Right. Or if it doesn't rise to that occasion, does the team need my professional knowledge to help change make a shift so this person can be educated with their peers and stuff? And
that makes a lot of sense. That makes a lot of sense.
So, and I really talking to the teacher, meeting with the parent, those type of things, we can really come and see and put down what is it that
that really is a paradigm shift. If you think about it, that's a big paradigm shift from that isolation of the student, pulling the student out of the classroom, and now really working as a team for the student and going toward universal design. I mean, where all of the students are going to really benefit, because you're not only teaching that teacher one thing for one student, but they're going to carry that over for all of their students, right?
And we see that happening now. I see teachers making accommodations and modifications based on the things that we've worked with other students. And so when I get this referral, they're pinpointing it down. Irene, I think it's right here. And I'm looking, I agree. You know what I mean? I said, yeah, I think we need to work on some things with this. But yeah.
Awesome.
That brings knowledge. And remember, we're supposed to come in and work ourselves out of a job and make those accommodations and classroom personnel to take over, and we fade out.
That's good. So you go in and you do that, and you document every time, and you have like flow sheets or something like that in the chart, in the EMR that you work with. So what happens when and you do this annually? You do a evaluation annually, is that right?
No, the standard is to do evaluations every 3 years. So it's a
Oh,
triennial evaluation. However, we are very good because, again, IDEA puts these standards on us is when the goals have been met, when the accommodations have been integrated into the classroom, or there hasn't been any progress, related service can be dismissed. So what we do is, and that annual IEP, we try to give a good functional basis of where they're at now compared to where they were when we initiated, so that we have that going, and that drives the service that we provide. And so we may provide first direct, then we move to a little more of a consultation, then we're out. So we're always preparing that parent and reinforcing that we're not here to fix or remediate, we're here to build those bridges. And we really want to put those accommodations in place and give the teachers the knowledge of, hey, this is what's going to work, and show that it does. And so that the student is not having to be pulled or anything else happening, so they can be educated all day.
okay. So then it sounds like you're doing a review, like when
it's like a review of documentation and everything to keep that in there. So more of a big progress report if we're going to look at it at like then a reevaluation. A full reevaluation has to be done every 3 years.
And that so when you're doing your so you have codas. We haven't talked about this too. So and this kind of goes in with documentation. So you have codas in the business, and they have to document as well. And we used to have to sign off on everything a coda did, right? We don't have to do that anymore. So tell us a little bit about how you ensure competency and your the way you handle supervision with your codas.
Well, right now we have 2 new codas, so we are trying to give them the time to learn, understanding that learning how to schedule and learning how to talk to the different teachers, giving them pointers. Is that I'm not on them like 100%, but I have conversations. We're in daily conversations. They can text me, let me know, ask the questions. I'm very available. We talk about students, what I saw in the evaluation, what's the history with them since I've been around, so that they have a better understanding of, oh, I can see what that means, and I see that. Of course, they have to identify who the supervising therapist is that way. And then I tend to make we've had Google Doc before where I can kind of read what's going on. If I see some deviation, I'll say, so explain to me what you meant by this. And then I'll say, oh, okay, because I'm not in the classroom all the time with each student. So there's a lot of trust that has to be shared, and I'm very big onto mentoring and knowing that I'm always available. So I think that every moment that we have with a student makes a difference, because there's a lot of other things that we have to understand. We're not there all the time. The classroom may be off the chain that day, but every moment that we're with that kid, even though I don't know if that really helped or not, it is, because that gives them a moment that they have a time to work on something that is impeding their abilities, and we may give them the best hope. So keep that open communication, feel good, let's go. And I do review stuff, so we're looking.
So do they?
But they have a lot of autonomy.
Yeah, and in my opinion, I feel like we could use codas probably. I don't know. I feel like this could be at every school.
Well, in the codas that we have here, I mean, I'm right now, since I've been here just for a short time, I'm actually going to start push. I want them to consult with the teacher. I want them to start owning the school environment. I want them to feel so comfortable,
like a part of it, right? Yeah,
they're a part of it. They're a therapist. They're not here just to meet goals and attain stuff.
Right.
I want them to learn from the environment, understand where those teachers are coming from, because they're an extra set of eyes when I'm making an evaluation as well. So all that information is imperative. They need to feel a part of it. They're the ones that are going to get these outcomes going. So I want them to have a voice in every part of the IEP process.
Right.
So,
So
mhm,
they do their documentation just like we would, the daily documentation. But would
mhm,
for standardized assessments, they can do the standard, they could do the bot for you if you needed them
sure,
to, right? Do you
sure.
have them do
Mhm.
that for you?
I don't I don't necessarily have them I have not had them do that part because since that's going to be part of my direct, it's generally myself. However, I do want a good analysis of what the classroom routine is. And if I'm not going to be able to observe for enough time, I may say, I need you to give me a rundown of what the classroom structure is, what the accommodations are, get that for me, and I will, it just helps, how's it working?
Yeah,
Do you see it? Yeah.
just let knowing that they could do it if you needed it, and
Yeah,
that
they
they
could do
understand.
they could do it if I mean, but since the goals are never oriented towards an evaluation, it's not often that they
That,
have to.
and that's a good
Mhm.
point. You don't teach to the test, right? We don't have to
Right,
do
right.
that. We don't have to do
Exactly.
that. Okay,
Exactly.
so that's good. So, and then discharging them, that can be kind of sticky sometimes. A lot of parents sometimes
Mhm.
don't want their children discharged, right?
Yeah, because they think it's like free therapy, and it's just a misunderstanding of what related services purpose is for. You know, I have I have had students for just 1 year and been able to dismiss, but I'm always very upfront with the parent. I really try to keep reiterating what related services is all about. It's not an extension of a clinic. Um, and we do not have the clinic, we don't have all that wonderful stuff. And that even though, you may score in a poor range doesn't mean that accommodations aren't helping you in the classroom and they're appropriate. So you don't need me to take out or work on those skills. You are practicing on them every day. So it's not necessarily that we need to remediate. And then use of assistive technology is very important too, since there's so many diverse things you can actually do. We are wanting the person, just like school-based OT is what OT is all about, is the true adaptation, either of the environment or the student, to what they have to do. No more, no less. Okay. So there's a lot of good stuff we can do. We are not burdened by financial constraints due to insurances or any of that. So it's fantastic, and we should be working ourselves out, and coming in as necessary. Does that make
So
sense, to support that student through their education?
you bring up the thought of the adaptive techniques or adaptive technology and working with the students, and that brings me to the models of practice that the
Mhm.
students have learned. And I can't help but think of the occupational adaptation model. Is that the one that you use? I don't.
That in this uh, area of practice, you have to know a lot. Okay, so you're going to, but occupational adaptation is going to be your fundamental one that you're looking at. You need to know your developmental frameworks, you need to know acquisitional, you need to know cognitive behavioral, you need to know systems and theories, because we're working with people that don't understand what we do as OTs, right? So
Right.
we have to understand, universal design. All of that stuff is understanding that the whole picture. So yes, occupational adaptation is really what drives me in this, and I have the freedom of doing a lot of that in the school district.
And the way that model works is that you are giving the autonomy to the student. So not only
Mm-hmm.
as much as, like you were talking about, you do the evaluation and you're trying to phase yourself out, and by doing that, it works with the fact that you're teaching them strategies, they're taking them over, you're motivating them to do it on their own. And that just, to me, that just fits with occupational adaptation. But there are other models that do have that I don't even teach, but that have technology involved in it. And
Yeah.
I didn't know if there was anything that maybe you used specifically, in the school system, that when you're looking at a client, or are you looking at, with us,
Well,
OTs are kind of weird, we look at the environment and the occupation and the person.
Right. But we're, if you're wanting to look at like more biomechanical type of frame of reference, we have to know that for our students that are low level. We have to
Right.
understand the you have to understand development, neurology. You have to understand, because you're going to have kids that need splinting and stuff, whereas we don't do that on our own. We need to be able to communicate with that outside therapist and make sure that wearing schedule is being done. And we're all actually have to understand what that is for. And if we're seeing a problem, then we need to communicate with that outside therapist. And that's how that works. So all the education that you're going to get in OT school, you really are utilizing in school-based therapy.
And
like you have to have a lot of tricks.
And it you do eventually get it. It all comes together in your head, right? It's like
it is. You have the opportunity to use it, right?
Yeah.
So I've worked in outpatient center for hands. I learned a lot, loved it. Biomechanics, here we go. Exercise, understand. When you're working with patients that have had a stroke, neurological development. Wow, you see it, core strength, proximity control for, to do distal work. All of that, you have to kind of know it. It really comes together. And, the occupational adaptation is really the framework we use, but everything else you really have to understand, because we have to explain it to people that don't.
That's right.
So why? Okay, well, they do this at the clinic. Why can't? Okay, well, I understand what they're doing at the clinic. How can we do stuff in the classroom that helps with that development, that doesn't take from their educational day, right? And so I have to understand and be able to accommodate that. So
and that's the occupational therapy value. We give them
Mm-hmm.
our words so that they understand it. And I think that's something that I've really pushed too, is the fact that we need to use our terminology, but put it on the client's level so they can understand it. And
Right.
We're not
Right.
physical therapy, right? We're not speech therapy. We're occupational therapy. So
right.
Okay, so another thing I was going to ask you, let me pull up my little list here. I think so we talked about the documentation process, and we've talked about the models of practice. As far as just going into what would you think that a student, if they were coming to you, what do you think they need to know to come to you as a fieldwork student?
Well, I just recently had my first, so it was great. I know you asked me many times, and I always said no. I'm sorry.
Yes.
It was just, caseload was very high, and I wanted to make sure it's hard to divert all your attention.
It is.
But really is having a good foundation on your neuroanatomy, understanding your frameworks, and what I mean by that is that you have the freedom. I call it a freedom, is that I'm walking into a classroom and I'm evaluating a student. I'm looking at everything. What could impact them? It could be visual, whatever. And once I've then done my evaluation, I've been able to discern that, yeah, this is a little bit more. We really need to work on this skill, or if we push this way, would we be able to acquire it and at least make it accommodation for something so that the teacher can help educate the student? Is that just be flexible, real flexible, because to learn to, this takes experience, but to be able to step back and look at everyone's perspective. We may be able to do all of it. I mean, I could teach a kid a lot of stuff, right? But am I the right person to do it? Am I going to be in that student's environment enough to take that role? So to be able to defer to the appropriate specialist or teacher and be able to be okay with that. You know what I mean? Because we say, oh, we can do all these things. You have to narrow it down to what we actually can make a difference in. Does that make sense?
That makes a lot of sense. So last thing, we've got about just a few minutes left on this one. Tell me what your favorite thing is about the school system, and what something is that you really, maybe some strengths and weaknesses about being an OT in the school system, and what you think about it.
Okay, my favorite thing is the fact that I can be an OT that I've always wanted to be. Okay, so meaning that I'm not worrying about compensation type stuff. Okay, so I'm not worrying if I'm not writing to continue to get payment for what I'm doing. I'm writing to get the best for a student. I'm advocating for a student's education. So that's fantastic. I feel like that I'm a better OT since I've been in the school district than anywhere else, even though I know all that billing stuff, right? It helps me here because I know what I need to do. The hardest thing is the lack of teachers. And what I mean by that is we have a shortage of teachers. And so we have teachers coming in that are alternatively certified that haven't learned developmental processing and all those different theories of learning to begin with. And they're learning on the job. And we have kids that it's hard, it's not easy. So if the environment isn't conducive, and I need to come in, I'm going to say it's not conducive, and what we can kind of work to is just getting them to get on the culture shift. Does that make sense?
Yeah.
And it's always changing.
Yeah.
It's changing. It's different teachers. I'm like, oh, so the fight is real, but it's worth it. It's just, difficult. That's the most difficult part.
So do you think it's worth for a new grad? Do you think a new grad it's a good spot for a new grad to take?
Anybody based on their own strengths and their heart and what they desire to do can be very, very successful in a school-based environment. However, I also am a true believer of getting some experience under your belt in areas that may be outpatient pediatrics, maybe even outpatient, whatever, to be able to see a wider range of diagnoses. Okay, so that as you build your repertoire of understanding, as you put the connect theory to actual application, and most important, success in the clinical environment, right?
Yeah.
Where you get that is better. This is hard insofar as you don't have the time. You only once a week, or maybe once every other week, or once a semester. You don't have that time. So sometimes what I see is that is just you believe that this is where we're going to lead, but the efficiency that you have, you got to develop a little bit of those skills. I always love to see therapists get a little bit of experience before they go, because you're alone a lot. But it doesn't mean you can't do it, because, if you seek help,
and if they go on a field work too, if they're in a field work.
If they've done a field work, or that's where their heart is, they're going to be better driven to do that. Mm-hmm. But just my experience is a little different. I have a very eclectic background that I think I drew from all of that makes this easier for me. But,
Well, it's been wonderful speaking with you, Irene. We are going to stop this one here, and then we're going to break down each section real quick with the levels of the classroom, and that won't take very long, and we will be finished. So thank you for talking about the documentation, and I will see you again in just a minute.